3, 2.
Good morning, everybody. I'm Dion Rogers. I'm Chief Clinical Nursing Informatics Officer for Kettering General Hospital. Welcome to our first digital seminar broadcast. Originally, we had planned an on-site event, but due to events, we've now switched to a broadcast. And actually, depending on how this goes, we're hoping to do more in the future. We're really thrilled so many of you could join us. I've seen the feeds on Twitter, all the sharing that's been done, which is great. So thank you for that. We wanted really to offer this out to people because we wanted to share our journey with you. Our ambition is to become the most digital hospital in England, and our CDIO, Andy Callow, will tell you a bit more about that in a few moments. So just generally, who are we and where are we? Kettering General Hospital is a 600-bedded district general hospital, just about in the lower end of the Midlands of the UK, and it's actually 127 years old at the moment. So was built very much, you know, in the last era. So not digital in terms of the estate or, in fact, the technology that we had up until recently. Kettering is a market town and is really famous for the boot and shoe industry that's unfortunately fading, but that's what we're famous for. So in the next 90 minutes, you're going to hear from some speakers from Kettering, some speakers from System C, who are our partners in our EPR programme. We are launching our brand new partnership video with System C, talking about our journey, and that will go ahead after Andy Callow's speech. Just a disclaimer. We are in lockdown, so I'm apologising for any lockdown haircuts that you may see. And a challenge that we're going to have is that we don't need to say you're on mute, because that's something that's really quite annoying, but regular occurrence on Teams. So I'm now going to pass you over to Anna Awalia, who's our Chief Allied Health Professional Informatics Officer, and who has actually arranged this event. So thank you to you, Anna.
Thank you, Dion, for your wonderful introduction. So there will be 5 talks. First from Andy Callow, Chief Digital Information Officer at Kettering General Hospital, who will discuss the KGH vision, our digital journey, and ambitious digital plans, and its rich clinical engagement and building his team and much more, followed by Jacqueline Davis. Jacqueline is the clinical adaptation specialist with System C. We will hear about governance and maintaining skills while going digital, and she might give us a few hacks. Followed by Jane Doyle. She is a senior clinical safety officer with System C. She will talk to us about the clinical safety and technology, particularly about areas staff need to know about and be aware about when it comes to safety. Then we will have Dr. Ajay Verma, who is a Chief Clinical Information Officer at Kettering General Hospital, who will tell us about the impact on patients due to the rapid transformation. Followed by Dr. Ian Denley, and he is a joint CEO with System C. And Dr. Denley will talk us through how he sees tech in health and health developing and challenges that might arise from the NHS being paperless by 2024 and much more. Followed by a Slido to get a quick feedback from you guys and a question and answer session. I would like to introduce our first speaker. So Andy was one of the first NHS Chief Digital Information Officers in the country to be appointed at a board level. Prior to joining Kettering General Hospital, Andy worked at NHS Digital and was the program director for NHS apps, which went from a concept to availability in the App Store in a little over a year. Andy previously was head of technology delivery for NHS.UK, the national website for the NHS in England, which received around 40 million visits a month. Andy oversaw the technology refresh of the site, during which time NHS.UK had the highest period of availability and reliability in its 10-year history. Andy sees huge potential to improve patient and staff experience using technology, but starting by understanding the needs of the users. It's lovely time now to just welcome Andy Callow, and we'll be handing over to him, but also just to let you know that he has got some brilliant news off the press that he would like to share with us. Over to you, Andy Callow.
Good morning, and yeah, thanks for joining us today on this is our first one of these webinars. Hope it won't be the last. So a couple of things first. So don't adjust your set. I'm wearing my third favourite shirt this morning just for the occasion. You know, hope you've also made the effort. And also look at the Twitter accounts there and make sure you follow, not least because as an exec team we have a Twitter league, and you know, I'm in danger of being overtaken. So I'm going to take you through some of these slides this morning and really start by saying why are we doing this in the first place. So if I can just advance. So we're doing this today because we believe in this as one of the design principles of making things open and making it better. And if you've been familiar with us over the last few months, we've started to do more blogging. We're trying to be active on Twitter and sharing what we're doing, because we believe that actually by sharing things we do make things better. And also it's fair to say we've built on things that lots of other people have done, and we'll touch upon that this morning. So as a hospital, we're working towards the day when clinicians can say we don't have to bring a pen to work, and our patients feel safe because of the information that clinicians have to hand. So this morning I'm going to be talking to you a few things about what we've done in our digital journey along the way. But it's worth noting that you know, you won't have heard of Kettering at Rewired or the CIO Summer School or some of the other forums, and that's probably you know, because we've come from a position of pretty low digital maturity the last time benchmarks were taken. So what's the point of today's session? What are the questions that we're going to hope to answer? So why does a trust like Kettering that starts off with a very low digital maturity, how does it get to go faster in its electronic implementation of observations than the GDE and the fast follower? Why does it go from 0 to 60,000 electronic handovers in 6 months? How do we end up as one of the highest users of Microsoft Teams in the whole of the NHS? And how do we have the audacity to have the ambition to be the most digitally mature hospital in England? Well, I'm going to attempt to talk you through that with a talk that I'm calling From Buckled to Aero. And this time last year, I was doing my cycle trip from Land's End to John O'Groats, one of the wettest Junes on record, although we've done pretty well in the last few days to equal that. And so basically, I'm just going to sort of talk through where we were. So if we start this journey in April 2019, we're a pretty digitally immature trust. We're designated to be special measures by the CQC, and we just signed a 10-year contract with System C, which frankly I found pretty alarming. You know, given that the flexibility and change that you really need to be necessary in the digital transformation space. However, we'd put a lot of effort into getting that procurement over the line, but it's probably fair to say we'd done very little thought in planning how we'd actually implement it. So we had the unicycle, but really no method to actually get it moving. So fast forward to August, and we're starting to get some of the components now to actually get riding. We put a lot of effort into creating an ambitious implementation plan, that one where we start to move at pace, secured the finance to support that, and brought in some extra people, most importantly, and ring-fenced them for a dedicated implementation team. So at this point, we've kind of got a plan, we've got the components and the right skills to do that at pace. So by December 2019, we've got a complete bike. This is a lovely bike. It's a steel frame built in Derbyshire. Nice runner, but not really a head turner, but it's doing some stuff. So by December, we'd implemented our theatre systems and linked it to our PAS. We'd implemented electronic observations in all adult inpatient areas with 500 new handheld devices deployed. We'd introduced safe and secure communications, and we'd introduced clinical noting in ED minors and mortuary. So things were going pretty well, and just trying to advance my slide. Ben, could you advance my slide for me, please? So, well, in March 2020, we all know what happened. This thing called COVID-19 came along and put a number of our plans at risk. So one of the benefits of having a dedicated team was that we were able to look at our implementation plan. We scratched our head at the puncture and took stock. And because of the infrastructure we'd managed to get in place by that time, we're able to do a number of things. So we're able to push positive COVID results notifications to mobile devices. We introduced a web app to record daily COVID situations to prepare our situation report that gets delivered daily. We'd introduced electronic observations in paediatric inpatient areas. We did a PAS upgrade as well. And we introduced virtual visiting using Google Duo and virtual consultations using Teams. So although it slowed us down, we're still able to do a number of important things to meet our COVID response. So by now we've got a pretty decent setup. This is a carbon frame bike, decent kit, comfortable for long days in the saddle. It's the price point is most sort of keen amateur cyclists area. But because we kept on pushing during the COVID period, we've got to a position now in this month where through electronic observations, we know where the sickest patient is in the hospital, available from any device. All our handovers are electronic. And as of today, we've gone live with a patient flow system, which gives real-time dashboards to aid discharge and patient movement. And later next week, we'll be introducing electronic observations in ED adults. But what about the future? So this is a professional bike used by teams across the world, extremely quick, reliable, full electronic gear shifting, extensive performance telemetry to make in-race decisions. This is a nice bit of kit. So where we think we'll be in December 2020, we'll have no historical notes in any consultation as our scanning project will have moved to BAU. We'll have efficient flow and discharge through our full deployment of patient flow, and we'll have redesigned our discharge and operations processes to support that. And we'll have universal electronic observations, including maternity, across the hospital. But that's not the end of it. We want to proceed. So if we go to March 2021, now this is a nice bit of kit. So this is an elite track machine, bespoke to the rider, precision engineering, not a gram wasted in getting from A to B as quick as possible. So by March 2021, we'll have implemented electronic prescribing and medicines administration. We'll have reached our target of no paper forms in 80% of the hospital. We'll have examples of RPA, robotic process automation in action, and increasing efficiency, and we'll have achieved patient access to records. So I've talked quite a lot about the bikes, but what about the support elements? So next slide, please. Oh, yeah, previous one, thanks. So in the journey from buckled wheels to aero wheels, I've spoken about some of the most obvious things, the components of a bike. But winning a bike race is not all about the bike. It's about nutrition, about training, about dedication, an extensive support network, all which needs to come together on the day. So if I look back and think about where we are now, what are the components that have made our progress possible, and why am I confident for the coming year? So I think what we did, we set out our stall about what's possible. We listened and adapted to user need and used agile methods where that was possible to adapt to change. We've got a whole trust commitment, which allowed us to secure finances and set in train and implementation of this ambition. And across the trust, we believe the impact this work will have on our delivery of patient care. We've had a heavy commitment to communication. We have an update every week across the trust, supplemented with deeper updates in various forums. And we've leaned heavily on our fast follower and continue to network shamelessly. It's definitely fair to say. We've got a strong CNIO and CCIO team. So we've got 2 CCIOs, 2 deputy CCIOs and 2 CNIOs, some of who you've already heard talk today and who you'll also meet. And I think we're also worth saying we're a Goldilocks trust. We're not too big that change is really too hard to achieve, and not too small that the change has no impact. And certainly we've taken the view that digital transformation isn't just something that you kind of do and then move on. It's an enabler for the sustainability and success of this organisation. So thanks for listening. Do follow me on Twitter, please, for the aforementioned reason. But before I hand over, what I'd like to do is share with you a video that we made with System C earlier on this year. So this is the first time ever that this has been broadcast, and I'm delighted to be able to share it with you.
Since filming this video, the NHS has been dealing with COVID-19. You won't see social distancing here, but you will hear about the fantastic strides forward we've taken on our digital journey. The resulting improvements in speed of clinical handovers and accuracy of patient observations have been a real advantage during this period, giving our clinical frontline staff more time to care for patients.
We signed a contract with System C back last April for 10 years, and so that coincides with a big ambition that we've got to take us from a pretty digitally immature hospital, to be honest, to one where we aspire to be the most digital hospital in England. And we're not just making that claim just because it sounds good, but we really believe that it is possible because of the things that we've already done so far, which gives a great indication of how willing our staff are to come on this journey with us. Introducing electronic observations was one of the first things that we did as part of the digital strategy.
It gives us the ability to see what's happening with patients in an instant, in a heartbeat, and to provide the response that that patient and individual needs.
E-observations has made a huge impact on our patient safety on Ashton Ward. It's helped to detect patients who are deteriorating much faster, helps us to escalate to doctors more faster as well.
Prior to the use of EOBS, you relied on the individual nurse to escalate appropriately, whereas now with EOBS, there is a guide and the message is there, a clear message of that escalation process.
So using the reports from the observations system allows us to use that within ward accreditation, our nurse sensitive indicators, see where each of our wards is performing. That forms itself naturally into dashboards that we look at from a divisional and a corporate and a board level. So it just makes the whole reporting process and the governance around the collection and the management of the deteriorating patient or patients in general so much easier.
Hot on the heels of electronic observations, we went towards care coordination and started to improve the way that communication happens between all members of the clinical body.
On our ward, we use it in particular for me to highlight to the senior nursing team which patients we'd like to self-pick from the urgent care setting. So I'll send the nurses a message saying please go and collect patient X from MAU and bring them up to our ward.
For the first time ever, we've been able to see handover from the multidisciplinary team in one place. So we have a doctor's profile giving the medical plan, the nursing profile giving the nursing care plan, and the therapist plan together. And it really does now seem that we can plan care in a much better holistic way.
One of the useful things about care coordination is the ability to take photographs. So I suppose that the way that's used them best is our diabetic foot ulcers. So we can take a picture on day 1 of admission and see how things progress through time and how they're responding to antibiotics and treatment.
The information that is provided through the handover functionality and eventually referrals, etc., will link back in to the EPR record. This provides us with a full handover audit trail that we can use to look back on patient care, particularly if there's been any incidents, any complaints, or just generally for improved communication for planning patient care.
We've got some amazing staff here at KGH, and one example is when we introduced the electronic CAS cards into ED in the height of winter. How amazing is that?
The patient notes are much more accurate because documentation is very important, and everything on the e-card has been put in systematically so that doctors are able to follow through to document without missing any steps.
It's very easy because we can click on the menu and then goes to GP information to see past medical history of the patient, or to see the previous CAS cards of the patient.
The village will never lose the patient's record, so we'll always have an electronic print somewhere, and then you can never going to lose what we did for the patient, and the information is there for everybody to see.
We've put a number of components in place, but that's really only the start. You know, as we're moving towards that paperless record, the next 12 months has got some really exciting pieces. As we enter into a group model with Northampton, having an electronic patient record is really going to help to support patients wherever they're receiving services. We're also supporting the move to the Northamptonshire Care Record, and we'll be using CareCentric to help support that. We see the benefits of moving to electronic patient record are so massive that we're going to continue at pace this coming year as we work towards being the most digital hospital in England.
Thanks for that, Andy. Great video. I just know now what you want for Christmas, a new bike. We get the hint. Thank you. I'm now going to introduce you to our second speaker, who is Jacqueline Davis. She's a clinical adoption specialist for System C Healthcare Alliance. Jacqueline actually qualified in 1987 and has worked in a number of places: theatres, ICU, as an advanced practitioner, ward sister. She's worked in clinical education and most recently head of nursing for surgery. That was actually at Kettering. She did that role. During that time, she's qualified as an independent prescriber, earning a BA Honours in Nursing and a Master's in Research and Evidence-Based Nursing. Also completing the NIBEV and Leading Care programme. In 2014, she went to work with System C, and she works currently on Vitals and is the clinical adoption specialist for all of their clinical products, using her experience to help the trust use technology and help patient outcomes and the work experience of healthcare professionals. Over to Jacqueline.
Thank you, Dion. Good morning. It's still good morning, everybody. So today I'm going to concentrate on talking about governance and skill maintenance when healthcare goes digital, which is really important. Next, please. So very briefly, as you're all aware, System C Healthcare is the provider for the Careflow electronic patient record. There's a list below of all the different functionality, but it's not exhaustive. But really to demonstrate that this touches every part of the patient journey, and with the goal to support timely and safe patient experience coming through the hospital, and also to help improve clinical people's and admin people's work lives by making the systems all integrated and seamless transition of that electronic patient record. Next, please. But patient safety, clinical safety is a core feature of governance, and that's what I want to concentrate on today. So obviously governance is a very big subject, so I'm not going to be able to talk to it all in detail, but if we touch on some of the key aspects that we need to think about when we're going digital, it'll give everybody just a thought on what you need to do if you're following Kettering's footsteps. So next, please. and it is part of the bigger jigsaw, hence the use of a jigsaw to demonstrate the point. So first part of that is policies and procedures. These underpin the governance of an organisation, and particularly in hospitals, we all have there's a suite of policies which support practice of all sorts, but specifically we're talking about clinical practice, and those are often supported by standard operating procedures, etc. When you're going digital, those policies may not any longer be fit for purpose. They were written often to support paper, so they need to be reviewed. So having a trust project team that has clinicians such as Kettering with their CNIOs and Anna as CH, I can't remember all the initials, the allied health professional, Chief Information Officer, is part of that group, and having the CCIOs and now the deputy CCIOs will help support the review of these policies for whatever digital functionality you're rolling out. So we need to think, they need to know the system well enough to review the policy to understand the decision points specifically that need to be considered as part of that policy. So if we think about vitals as an example, there's key decision-making points that people can do, such as putting a patient on scale 2, putting them on end of life, extending their protocol. Those are all decision-making points that could impact on patient safety, therefore they need robust governance around them. So we need to understand who can do that, so the role-based access is really important. Who will be allowed to make those decisions? And also, when making those decisions, what other parts of the policy come into being? So does it have to be documented? Does the clinician have to sign it off? What is the whole governance process around those decisions? Those need to be very clearly articulated in the policy. So the trust staff know what's expected of them, but also if things don't go so well, we can manage those issues. We need to also understand the current processes, how things work now. There is no point in putting a suboptimal process into a digital format. It may help, but it may not necessarily fix all the issues you've got. So having a really good, robust review of processes is also critical to the safe use of a digital system. Clinical leadership and trust leadership, as I've already pointed out, has been key at Kettering. That buy-in from ward level leaders to the trust leadership, supporting this journey and really actively engaging in it has been, I think, really key to the Kettering at this point are punching well above their weight as far as digital this digital journey is concerned, and a lot of that is around the leadership involved. And very briefly, because it is a subject on its own, thinking out the project or programme governance structure. So thinking about a lot of these systems need configuration, both at local and at system C level. So how does that get signed off? What is the governance, trust governance process? Who can make those decisions? And then again, testing. So making sure that it's robustly tested before it goes into live to meet with all your regulations, which Jane will talk about in clinical safety. Next, please. We're thinking about then information governance, and in many ways it's a bit easier because you don't have a lot of paper lying about, and as we go forward into there, hopefully eventually no paper. But currently you've got charts at the bottoms of the bed, or folders, or notes lying on ward control, notes trolleys that should be locked but aren't always, various things like that. And the main thing is, as Dion's hashtag is about, is paper out of pockets. And I think every trust in the country will have had situations where handover notes with patient identifiable data have been found in car parks, people's rubbish bins, on buses, in supermarkets, as somebody's pulled something out their pocket and their handover note has come out with it. So that is a real win for information governance. But then alongside that comes different considerations, so about who can access, what they can access, where they can access it. Something like Connect can be accessed outside the organisation. Again, it should be by professionals who have a code of conduct, but we need to make sure that they are also people who have access because they work for the trust. So we need to think about particularly locum and agency staff, how we onboard them from a training and education perspective, but also those legalities of having access to patient identifiable data for a particular space of time, and so therefore a robust process around how we end that access when they are no longer there, and really ensuring that staff are aware that if they're working with an agency member of staff, they never share their login and sign in and hand over a device to somebody else, because it's all auditable and it is all under their login. Next, please. So leading on from that is the training, not only of the staff that are currently and how we keep their skills up to date and any changes, and when you upgrade and you maybe have a new functionality, like shortly you're live with paediatrics, but you'll be taking paediatric sepsis. So it's about how you keep training the staff on new stuff coming out, but also about induction and business as usual training. One of the key, I think, game changers at Kettering was when the Trust IT team were brought on board and into the programme, and really put a good structure around that training, and also an audit of people who had been trained. A good training strategy, so understanding how to use cascade trainers, super users, etc. is important. And the opportunity for practice development to get involved in observational studies to make sure that the practice on the wards is as they would expect. As I say, there's no point in putting in a digital observation system if practice on the ward, if they continue to, for example, do rounding around vital signs and not follow the EWS protocol by the patient's EWS dictates. So again, getting practice development involved in looking at practice on the ward is important. Next, please. And coming to that, I talked briefly there about audit. So we need to think about our baseline data collection. There is a lot of information when you go digital that you've not had before, that you haven't had easy access to before. And if we think about as a senior nurse having to do investigations and answer complaints, the length of time it takes to wait for notes, to find notes, then to find pieces of paper and notes to correlate that TPR chart with that note in the clinical record and what was prescribed, all of that can take an age and can be very difficult to evidence the complaint or the SI. So this will give you a lot of information. So understanding what information is available to you is really important. But also we've had, the trusts, whichever trust we're talking about, have had to put in a business case to get the money to fund this digital programme. So being able to realise the benefits, which is a work stream and we support, so that we can understand the clinical outcomes, which obviously for me is the most important, patient experience, but also operational benefits and financial benefits, all of which every trust needs to be able to evidence. To be able to do that, one of the key things is that baseline data. If you don't know where you've been, you won't know where you've gone or where you're going. So you really need to be able to baseline as much as possible before you move forward with your programme. And it could correlate with other metrics and observational studies and things like your emergency length of stay, multi-organ failure, unplanned admissions to ICU, cardiac arrests, etc. All of those can help correlate, and not forgetting external bodies such as CCGs has already been mentioned, the CQC. If you're on NHSI's radar, etc., they all want data, and this gives lots of data that you can use to evidence the improvements and the quality of your care. Next, please. I'm not going to say too much about communication because Andy, I think, has really covered that, but people need to know what's happening, when it's happening, where it's happening, why it's happening. Unless they don't buy into it, they won't, because everybody thinks as soon as change is coming, what's in it for me? It's the first thing that any human thinks, and they need to understand why it's happening. The public also need to be aware So engaging the trust communication team quickly to think about innovative ways to communicate using local radio, local papers, things like that, particularly with the functionality that's using mobile devices. You don't want patients in the public coming in and thinking they're all on their phones. Hopefully the professionals will tell them what they're doing anyway, but it's good if they understand what's happening before that. Next, please. And finally, and something that wasn't part of the initial jigsaw, but I think is a key part of the whole jigsaw of clinical governance, is skills maintenance. It is very easy to forget how to do things, and when you go digital, as the years progress and we go from year 1 to year 2 to year 3 and so on, that it is incredible how the ability to write a drug chart, to administer medications from a chart, to complete a TPR chart disappear in the staff. People have rotated round, nurses have trained, excuse me, at Kettering using vitals, so they've never had to fill out a TPR chart. So it's really important when thinking about statutory days, training day, annual updates, that you think about using, the education team think about how to make sure that staff understand how to use paper. As part of governance, there's business continuity plans. So if the system goes down, and it will go down, whether it's unplanned or planned for upgrades, etc., staff need to know what to do and how to use paper, because some of the systems will inevitably go back to paper. So for example, one trust who'd used vitals for over 10 years, when they took TPR charts round, the trainer was wafted a TPR chart by registered nurses, these were. One said, "What's this? What am I supposed to do with it?" One said, "Well, I don't know how to, what does this, how do I complete it? How do I count an EWS? I don't know how to do that." And somebody else said, "How's this going to tell me somebody's sick?" You don't want to be in that position. So you need to think about skills maintenance over the course of the coming years. And I think that's me rushed over governance, very high level, very briefly, but hopefully made you think about some key aspects of a digital programme. Thank you.
Thank you so much for that, Jacqueline. And I have to say, on a personal level, myself and Jacqueline speak almost weekly, if not more than once a week. And actually, Jacqueline's knowledge of the systems and of how to apply them in practice has been invaluable. And I would say that relationship between us and Anna and Jacqueline has been paramount, really. Okay, we're now going over to Jane. So Jane Doyle is System C Clinical Safety Officer. We're a bit pushed for time, so we're going to skip your bio, Jane, if you don't mind. You can read it on the slides and go straight into your presentation. Thank you very much, Jane Doyle.
Hi, thank you very much. Thanks, Diane. Right, as I said, I'm Jane Doyle. I'm a Senior Clinical Safety Officer with System C, and I've been with them for 7 years now. Next, please. It's coming. There we go. Okay, so what is clinical safety? Clinical safety is not just IT. Obviously, it covers all sorts of environments within the hospital, and it's obviously reported that adverse events can occur in 10% of all hospital admissions. Now, that's quite old data, and more recent evidence scan puts it between 3 and 25%. But half to a third of those events are thought to be preventable. So we're looking at things like wrong drug administered, wrong site surgery, clinical test results placed in wrong patient notes. So not all that is IT related, but it's all tied together. Next, please. Okay, so we have quite strict regulations around what we do. What we try and do as a company is that we're looking at prevention of known risks within the clinical workspace, and then we're looking at prevention of risks caused by the system through use or misuse. And as we have regulations, we have DCBO 129, which is our management plan for manufacturing health IT systems. The trusts have their own regulations, legal regulations regarding how these things should be deployed. And everything that we send out and that you receive has to have had safety work completed on it, and has to be accompanied by a report or a certificate. Okay, next slide, please. Okay. Now that's not, sorry, the formatting there has gone a bit screwy, but anyway, we have proactive and reactive processes. So when we're looking at proactive processes, we're looking at the very early phases. So we're looking at the design and the development, and then the testing to make sure that that the system is good and safe for use. And also the trust can review proactively. So as Jacqueline was mentioning, things like the business change reviews and user group meetings are very useful, testing in UAT, and that helps inform the trust side's risk register and hazard log, which is helps to then inform your testing and what you need to put in place through training and procedures, standard operating procedures. The reactive process is where trusts are raising issues to us, and we can assess these when we know about them and monitor clinical risks. So we monitor them all the way through from the raising to the deployment and making sure that they are safe and are functioning as expected in live. Okay. We have next slide, please. Now, when we assess them, we are looking, and people go, oh, that's a really bad risk, but we're looking at the consequences of something that might happen, but we're also looking at how often it might happen as to get a risk rating. So if you ever see one of our assessments on a call, it will have a low or a medium or a very low risk rating on it. So please don't assume that we are paying less attention to a risk because it says low. We know it's a significant risk, but we're looking at ways to assess how quickly we need to fix these things as to how likely they are to happen. And that's the National Patient Safety Agency's standard matrix, which is used across the board. So we are a team of 4. There's Debbie Francis, our Patient Safety Director, I'm the Senior, and then we have Rebecca and Simon, who both work as CSO. So there's 4 of us here. But similarly, it's everybody's responsibility is clinical safety. So we rely heavily on our whole team to point things out, to flag things up to us, and it should be the same in a trust as well. Everybody's responsibility is clinical safety, whether it's IT or clinician, clinical based. Okay, next slide, please. So, nitty gritty. Why do we need it? Clinical safety. I think it helps to think about an electronic patient record the same way you would think about anything else you do clinically. Looking at these 2 bags of IV solution, a cursory glance would look, it's potassium chloride, okay, but you have to concentrate on the detail. So we're looking at that, and one of those bags has got dextrose in it and one of them doesn't, which can have a vastly different outcome depending on which one you're using. So if you think about the electronic patient record the same way, you wouldn't give a drug to a patient without checking the name with them if they're conscious, checking the wristband, checking the drug, checking the expiry date, checking the dosage. All the things you would do normally as a clinician, you would do with an electronic patient record. So when you're looking at the software, when you're looking at the page, you always check you've got the right patient, you've got the right drug, you're doing the right appointment, whatever it happens to be. It's an aid. The software is an aid, it's a valuable aid, and it will cut clinical safety incidents down, but it's only as good as the people using it. So you have to be very aware that what you're looking at is correct for what you're about to do. People are people. They get used to doing things in a certain way, and they always know the save buttons on the bottom right hand corner of the screen. Whatever it is, it's never assume, and it doesn't replace clinical judgment. Okay, next page, please. Okay, so we have all our documentation accessible to customers. We like to be open and honest and what's the word? I've gone mute now, haven't I? I'm not mute, but all the documentation anyway is kept there so that it's accessible to customers, so they can see everything we've fixed. That's anything clinical safety linked, and anything that's still outstanding. So it's always useful to review your clinical safety reports that you're getting for any releases to see what the content is, as well as the release notes. They should be looked at hand in hand, and then that gives you the full picture of where we stand. Okay, next slide. Thank you. How to raise a clinical risk. So we have the JIRA system for raising issues, and it's very important, if we're to see them and assess them and help you get them fixed in a timely manner, that we know there's a clinical risk incident raised. It's one of the options when you open the screen to raise a request as a clinical risk. So if you think there's any content there that you are concerned about, it's important you raise it correctly, because as soon as you raise that, we get an email. The team get an email, so it doesn't matter who's around, we all see it, and then we can address it. If it's not raised correctly, we don't always know about it until later in the day, or later, much later, when somebody mentions that there's clinical risk in the comments and somebody thinks to forward it. So it's really important you raise them right, and then I'd rather see one that wasn't and be able to say, I think that's okay, and have that discussion with you, than miss one that might be. Because that way we can make sure things are fixed, you know, as soon as reasonably practical. Okay, thank you. I think that's us.
Thank you so much for that, Jane. Really good in-depth conversation about clinical safety. We're now going over to Dr. Ajay Verma. Ajay is one of our CCIOs within the organisation and consultant gastroenterologist also. Over to you, Ajay. Thank you.
Hello. Can you just wait to say you can hear me?
We can hear you.
Yeah, wonderful. Thank you. Right, I hope everyone has enjoyed this digital webinar so far as we talk about our journey to be a modern digital hospital. Now, to explain this term, we are striving very hard for a fully electronic patient record in which we can ultimately have a paper-free clinical environment. My name is Ajay Verma. I'm a consultant gastroenterologist and physician. I was appointed here at KGH in March 2015, though I have worked for 10 years in KGH across 3 spells. How I got into this role? In 2017, I was approached by Mark Gregson, who was the head of digital care services at that time, to be a CCIO, a Chief Clinical Information Officer. And we started to think about what that role could involve and what work streams could be involved with that. And that autumn, myself and my counterpart, Dr. Adrian Irina, who's an ED consultant and the Clinical Director for Urgent Care, we both applied for this job and were jointly appointed as CCIOs for KGH. And I was surprised when I look back at that to see that it was 3 years ago. And I just, this morning actually looked up my interview notes for the time that I'd written down to kind of imagine what my role encompasses. And I put on there to be the clinical face of the IT team, to support, be a sounding board, be a cheerleader, and be a colleague. And 3 years later, I think that was an accurate description of my role. One of my personal strengths and my personal weakness is I don't like things that don't work well. And that is a real issue when you work in the NHS. It is often a compromise working in this environment, given the resources that we have to hand. However, in my mind, if things don't work well, I want them to work better. I don't think we should put up with something that doesn't work well at all. This device here, see here, a smartphone. It is an amazing device. A significant part of my life is available on this device, be it my kids' photos, messages to my family and wife, my research projects, my Twitter feed, and thanks to Carefo Connect, my patients' updates when I'm working on the ward. It seems incredulous to me that we can order items when online shopping and you can track the delivery van to the street it is on yet we are unable to do this for tests we arrange for our patients. This facility to track should be available not only for clinicians, but for the patients themselves. For far too long in the NHS and at KGH, we have been beholden to bits of paper, which can only be in one place at any one time and only viewed by the person in possession of it. And ask yourself an honest question. In your lifetime, how many bits of paper have you lost, have I lost in that time, and have been lost within the NHS? The power of digital potentially enables us to deliver better care, safer, efficient, informed, smart, and accountable. And these all meet our KGH care values. In my mind, there is very little downside to going digital. Part of my role is to advocate for all. Any system is in place is only as strong as its weakest user. We can't be aspirational alone. This applies to patients and clinicians. However, we mustn't underestimate human capabilities. In our discussions about how to develop services for patients, many have told me that the older generation won't embrace technology. But tell that to the millions of parents and grandparents around the world who have kept in touch with their children and grandchildren via video calls during the pandemic lockdowns. However, we still must protect those who struggle to use technology or those who don't have access to it. This group is always on our mind. As well as this safeguarding, my role has been to identify and encourage new clinical leaders to support the CCIOs, the CNIOs, and the digital transformation team to achieve our aims. We've been pleased recently to welcome 2 deputy CCIOs, middle grade doctors Kieran Naik and Solange Cerner. Kieran has been working with the ED team, especially with projects such as clinical noting. Solange, who works with me on the ward, has worked very hard in implementing Careflow Connect for handovers and referrals. It is now widely utilised in our clinical practice, and it was something that was difficult to imagine just a few months ago. The last 3 years have seen a rapid digital transformation for KGH, from a paper-based backwater to an innovative cutting-edge organisation. We have made huge strides, be it the implementation of Vitals and Careflow Connect and the start of clinical noting. We look forward to the next steps: clinical noting, order comms, patient flow, scanning software, electronic prescribing. The next 3 years are looking to be even more exciting for KGH and our digital ambitions. I won't stop supporting, being a sounding board, a cheerleader and a colleague, and I can see a day not too many months away when I will not need a pen to do my clinical job.
Thank you very much, Dr. Ajay. This will stay with me: safer, efficient, smarter, and accountable. Thank you very much for that. Now introducing our final speaker. So Dr. Ian is responsible for corporate affairs, research and development, and an overall running of the company. He has over 25 years experience in the software industry, with at least 15 specializing in healthcare. Dr. Ian has led a number of public and private companies in the health and social care sector as CEO or chairman, most recent co-founding Sharewater Healthcare Investment and Sharewater Systems with Marcus Bolton. He has also chaired, he is also a chairman of Graphite Healthcare. This is now Ian's second stint as chief executive of System C. He's left the company with the first time following its sale to McCarson's in 2011. During the previous tenure, Ian oversaw the development of the Medway products and suite, a number of strategic acquisitions, including that of Liquid Logic, the company's flotation on AIM, and its sales to McCarson's. With a warm welcome, we now introduce Dr. Ian Denley. Thank you.
All right, thanks for that, Anna. Okay, so I'm going to do a bit more on the technology side to kind of finish off the presentations today. I've been in the healthcare software business now for about 25 years, and we've grown System C and GraphNet over the years, from a handful of people 25 years ago to nearly 700 people now in the UK. We're a UK-based company, software company, one of the few left standing actually at the moment. And we take our role in the health service very, very seriously. We have about 350,000 users of our software across the NHS and social care with our Liquid Logic solution. So if we just go to the next slide, please, Ben. So what we've tried to do, we're kind of as ambitious as Kettering, except we're trying to do it across the whole of our user base and across the whole of the health and social care sector, if you like. So this slide sort of summarizes really the way that we think about the number of systems and the complexity of the systems that we have to provide. So if you start in the center with the PAS and EPR, and by the way, we've drawn this as a kind of series of clouds, because obviously every software solution now is moving towards a cloud-based, a mobile-based approach to the design and deployment of their software. And Kettering is with us on that journey towards cloud-based systems. But starting in the center with the PAS and the EPR, the heart of the health service in many ways is the acute sector, the acute hospital, and that sector focused massively over the last 20 odd years on how to organize patient flows, how a patient arrives in a hospital is dealt with clinically, collaboration between clinicians and other staff, how the safety of those patient journeys are managed, and providing the specific modules, if you like, to support the patient's clinical journey. We've heard today about electronic observations, moving from paper charts at the end of the bed to handling those on an iPod, where we have mobile systems now that help us deal with electronic prescribing and with care collaboration and so on. An immensely complex clinical environment within the hospital. And that progression across modules and the integration between modules is obviously critical to supporting good, high quality care. Wrapped around the acute hospital, we also produce a shared record. So a shared record is really where we're pulling silos of data. It might be your GP record, data from your community care record, your mental health record, social care, and so on, into a single repository of data, which can be shared across the care community. And Andy's mentioned already the Northamptonshire record, which we're working on, which will do just that for the whole of the county. This means that information about a patient is available wherever it's needed in any care setting, and it gives us tremendous power to start clinical collaborations and different patient journeys supported by the availability of data. This means that as an out-of-hours doctor, for instance, you've always got the right information at your fingertips in order to be able to prescribe, work out what needs to happen to a patient that you may have never met before. Surrounding that, we're doing considerable amount of work on population health. And by that, I mean some of our shared records have many millions of patients that we hold data for, many billions of encounters and data points. And we're using the power of cloud technology now to be able to analyze all of that data, not for secondary uses, but to support operational care of patients. This means that we can provide case finding tools, we can start to do risk stratification, we can look at social factors and their effect on healthcare. We can bring data together from all kinds of settings and be able to analyze that data and use it to support operational care. Very powerful tools, and we've obviously been doing a lot of work during the current pandemic to support the analysis of data right across the country. And then the final element, if you like, of the series of concentric clouds is the personal health record. Ultimately, this is an area that's really just starting to take off, I think, but holds huge potential to help patients get more involved with their care, manage their care better, and to be able to use a wide range now of emerging devices, so the Internet of Things or wearable devices that will allow the patient to very actively contribute to their own care, to their care from home, supported by clinicians, to being able to make their own appointments very easily, both at the GP surgery and the hospital, and really get patients engaged and excited with that whole process of caring for themselves and being engaged with their clinical care. Okay, next slide, please. Okay, this one's a bit complex, but the main idea of it is just to say that we've been in this business for a long time, and over those 25 years we've written millions and millions of lines of software code to support changing practices across health and social care. We've acquired a number of companies along the way that have brought us innovative technologies or innovative solutions, all of which need to be integrated together. And obviously we've invested, many tens of millions of pounds in building the sort of software solutions that we now provide. What we're doing at the moment is we're working on modern technologies to allow us to exploit all of that investment and to build out from all of that investment over many years by breaking the code base down in our solutions to smaller components that you may have heard people talk about, APIs or microservices. These are just simple components, if you like, that allow you to assemble new functionality from the investments that you've made already. And Andy spoke earlier on today about taking Patient Flow live this morning. Patient Flow is a perfect example of that. So Patient Flow draws data from many of our systems. It uses APIs to pull that data together, and it presents a new interface and a new way of looking at patient flows across the organisation. Now, we've worked with Kettering very closely. It's the first trust to take this live. It's been a really exciting project and a very agile project that's involved a lot of effort, both from trust staff and our own staff, to create what's effectively the first version of this software that will evolve now over the coming months to really meet the needs of the trust. And we're able to do that by modern ways of working and working in a very agile way along with the trust. I just wanted to say a couple of things really about working with the trust and what's making it successful. So I think the ambition of the trust is very exciting, and the sort of dedication that people are putting into moving forward at speed is very exciting for a supplier. Doesn't always go smoothly. So Andy's obviously a road bike rider. I'm a mountain bike rider, much more used to the bumps and lumps of charging downhill, but we won't go there. It's a difficult job, and it's to both produce the software and to meet the demands and changing demands that are needed across the health economy. The most important thing for me, I think, is the relationship with the trust is really strong at all levels. There's a willingness both from our teams and from trust teams to work together. We work towards really high quality solutions, but we don't make the perfect the enemy of the good, which I think is a really important point in terms of how you move forward with novel solutions over time. So I think the trust journey towards paperless is very exciting, not without a huge number of challenges, but I do think that the relationship between the teams, the desire to move quickly is a very exciting place to be, and we're delighted to be working with Kettering on that journey. Thank you.
Brilliant. Thank you so much, Dr. Denley. Personal health records. So patients have the ability to contribute to their own care. That for me is absolutely amazing. And I think this journey to transformation is just going to be phenomenal. So we're going to be just finding out one or two things from you guys with this little bit of a Slido poll. So there's going to be a link to Slido sent in your questions and answer section now. Please click onto Slido, enter the event code 45516 in there, and there'll be a couple of questions coming up for you to answer. Please answer those questions while I hand over to Dion Rogers to go through the question and answers. So please ask the questions. Thank you.
Brilliant. Thank you, Anna, and thank you, Dr. Denley. So we have had some really exciting questions come through, so thank you for those. I'm going to read out the questions and then point to the person I think would be most pertinent to answer it. So first one, Andy, this is to you. What is the Trust's plan to bring the systems to the point of care with mobile devices such as workstations on wheels or dispensing carts?
Hi, thanks, Dion. So we already have workstations on wheels or computers on wheels around the Trust, and we're also increasing the number of handheld devices that are available. So I think we're already making some progress along there, and as part of our EPMA project, we're introducing what's called the 2-in-1 devices, where they've got the touch screen and the keyboard involved to help people have that information at the point of care.
Brilliant, thank you, Andy. Mike Alvey has asked, hi, I wonder if you could inform us whether there are any plans for outpatient services to transform towards digital care. Ajay, are you happy to answer that question? Ajay?
Yes, absolutely. Yes, sorry, it was just camera on and unmuting. Yes, there will be. Things like order comms, we've already started with some of that in terms of order comms for radiology and then order comms for pathology coming soon. And also clinical noting, I would love to eventually extend it into outpatients. But we have to remember that outpatients and inpatients are very, very separate. And I think the priority will be to get the inpatient service sorted soon. But ultimately, when we have our big ambition to be a paper-free clinical environment, that does include outpatients. So yes, there is a plan to extend it, but it's just a slightly different work stream and it might take a little bit more time.
Brilliant. If you can just stay on this question, Ajay, the next one I think is linked. So it says, what are you doing to take the patient along this journey with you? For example, patient portal, and do you have patient representation on project boards? I was just thinking about the virtual clinic work.
So that's a really important question, and that's something I do think we probably need to do a little bit more on. We are getting feedback, so we are trialing something called remote clinic appointments, where on Monday I did video clinic appointments using Microsoft Teams. Now we're not inventing video appointments, but obviously using Teams and the software available to us. It's a trial nationally, and we're one of 3 centres, and part of that will be patient feedback. But yeah, that is my role as well. It's very, very important that we take the patient along with us. And I think that's, we're trying to design systems that not only work for clinicians, but work for patients as well. And as I said in what I spoke, my vision is that a patient can use their connections online to track their care and see what's happening with them, and actually, be able to interact, even maybe cancel an appointment online using a tracking device. But we'll get there. It's just going to take a bit of time.
Brilliant. Thanks, Ajay. Okay, we have Ian Hazel from, I presume, Chesterfield, saying many synergies between KGH and Chesterfield Royal Hospital. Similar start point, similar strategy. Some questions. How did you get the necessary board buy-in? My understanding is KGH has self-funded the digital improvements. How was this achieved? How are you maintaining the funding during COVID-19? And what are the key benefits and measures you are using to demonstrate these are being met? Many thanks. Is that an Andy question?
I think so. Thanks for that, Ian. Good to hear from you. So yeah, let's go through them. So the necessary board buy-in. I think it sort of started with our chief exec, who was right from the off of coming in, has really put a lot of energy behind our digital program, and so we agreed our digital strategy in September 2018. I've been working to enact that ever since. So it's been a process of perhaps with us starting behind a number of people, observing the progress that they've made and the benefits around that, and deciding to really go for it as a trust. And that's exemplified by it being one of our strands that we've put towards our Journey into Outstanding programme. So yes, it is self-funded. So it was a priority that we agreed as a trust to commit to putting the money in to support the implementation, and you know that comes at a cost against other things that we want to do. But I think it reflects our belief in that really going for this and going for it at pace brings real patient and staff benefits. How we're maintaining the funding during COVID-19. So it was a ring-fence budget, and what we did at the start of the process in February-March time was look at the impact of COVID-19 and remodel what our programme was doing according to what were the most benefits that would be delivered during COVID-19. So for example, unfortunately we paused our scanning project because that wouldn't have made sort of got through the process all the way in time to sort of benefit immediately. So what we've done is we've focused on getting all referrals electronic, pushing ahead with electronic observations into ED and into PEDS, and then we're also looking around our implementation of patient flow, which is today. So a really big thing there, really excited about that, and that makes a massive difference about being able to understand what our discharge process, what the different situations is on each ward, and having that visibility for those changes done at the ward level reflected up at the ops level is really going to make a big difference. And your final question is around what about the key benefits and measures. So we've, as part of our business case, we built quite an extensive business benefits program around that, and we're looking at the various things. So, for example, one sort of small thing is when it came to observations of patients, we were doing spot audits and we were kind of understanding what the performance was there. What we're able to do now is to see that 99% of our patients all receive their observations on time, and that's something that we've never been able to do before. And so it's those sort of things that we've sort of built the case around. And Ian, happy to have a conversation with you about sort of some of the other things that we've got in train in that benefits plan. So Dion, shall I hand back to you?
Thanks, Andy. I'll take over from here. That was extensive answering. Thank you for that. Robert McMurdo has asked a very pertinent question. Digital transformation by its very nature upsets a lot of apple carts. What challenges did you face and how were they overcome? I'll put that out to the panel in a moment, but just from my point of view, I think it's fair to say that the organisation was really ready for a change. As Andy alluded to, we went into special measures about 3 years ago, and that's not a reflection of the staff at Kettering. The staff at Kettering are very caring and are very conscientious, but we just didn't have the services in place to make it better. Another one of Andy's comments. So I think one of the things was that our staff have been really happy to embrace it, and I think having a really robust digital clinical team to provide the translation between services has really been one of the things that we've overcome. But any other panel members want to answer that question from your point of view?
I'm happy to say a few words if you like.
Yeah.
I think the question's absolutely correct, though some things create more require more change to bring them about than others. So if you track back a few years, let's say, with the introduction of PACS systems, that actually was incredibly disruptive, but didn't involve a lot of change to clinical practice in many ways. You know, that was a very successful national program, if you like, that became very easy for trust to adopt and was transformational. I think if we take another example, such as electronic observations, that's a slightly harder job, but actually nursing staff embrace it, move with it really quickly, and quite quickly forget paper charts altogether, as Jacqueline was saying. And then you might come to perhaps more difficult digital change programs like EPMA and electronic prescribing, where you've gone up a complexity level, removing paper across the whole of the prescribing piece becomes a different challenge again, in order to get rid of all the eventual supplementary charts and how to work with infusion. So complexity plays quite a bit in how far the apple cart can be upset, and how quickly people are prepared to move, particularly in clinical safety type environments.
Can I add?
Thank you, Ian. Yes, of course, Jacqueline.
I just also wanted to add that I think part of the change process is that user experience. If the technology is easy to use, intuitive, and people are therefore confident in using it, then that helps them along that transformation. And for example, taking Vitals First, which is a very intuitive system for nurses and healthcare assistants who will be using it, that gives them confidence. So I think, Dion, you might agree that when Connect came along at Kettering, because nurses and HCAs were already used to the intuitive vital system, it didn't seem so difficult to take the step into using handover on Connect. And I think so that user experience is also very important. And we have to remember, like I said during my presentation, every human being, when it comes to change, thinks, what does it mean for me? So we have to be able to show them that future and create that vision that it will work for them and it will make their lives better, and particularly the patient outcomes better. Thank you.
Yeah, absolutely. Thanks for that, Jacqueline and Ian. We've got 2 more questions, and then we'll hand over to Anna for the close and the results of Slido. This one, I will ask this one first. What size of implementation team do you have? Anna, are you able to answer that?
Say that again. What
size of implementation team do you have?
Oh gosh, our implementation team has just been growing. It's one of those things that we need to try to recruit as many people as we can, because I think when it comes to rolling out digital technology, you've got to get people that are willing to kind of adapt to and want to be part of that team, and are doers and are ready to make it happen. The size varies. It varies on the project. If the project is a big project, you will need teams from the suppliers, from the hospital, and from as many people that want to get involved. And I think we've always, and Dion, you can testify, we've always been an organisation that has embraced people that have wanted to make changes in their areas. And I think part of the digital ambassador program that we have done is testament of what we're hoping for, in terms of ensuring everyone within the hospital is part of change, and they understand what change is and understand it's going to be continuous. We're not going to stop at all. This change is going to be ongoing for the hospital, and I think it's now time for us to all be part of it. So I think the size of the team, it depends on the project, it depends on the amount of areas you're going to be affecting, it depends on the type of the complexity of the project for you to determine the size of the project, but the size of the team. But it's a big variance. There's a lot of variance to that. I hope that answers the question.
Thanks, Anna. This is the last question. We are getting a lot more questions through. If we haven't got to your question, we are going to put out some comms where we can answer them off the back of this seminar. So the last one, Andy, is again back to you or Ajay. KGH has partnered with NGH as part of a group model of healthcare delivery. This will include shared clinical patient pathways across the organisation. So the question is, how do System C at KGH and EMIS at NGH work together to support this clinical business model, or will shared use of a common EPR be required ultimately?
I can try and answer that, Dion. The answer is we don't know. I think what will happen is it depends on what services are developed. So the EPR program and whatever digital services we put in place are there to support what clinical services are in place. So until we know where this model is going, we won't be able to know specifically what is needed for that. So at the moment, we do have shared services across the patch where patients are referred back and forth between Northampton and Kettering for clinical care. So we're working quite hard with our platforms to make that easier and make that work better. And that's what we want to do. As new services are developed and this model evolves, then we'll have to look at our plan. But I don't think we can say from now that the grand plan is to have a single portal EPR yet. Maybe one day, who knows, but I don't have my crystal ball with me today.
Thanks, Ajay. Okay, Anna, over to you with results for Slido.
Okay, thank you, Dion. So it's been actually very interesting. I'm going to share my screen with you just to show you what the results have been. So give me 1 second to share my screen, guys. I hope you can all see my screen now. Yeah, brilliant. So this is showing, we've asked from what sector are people from, and we can see we've got about 48% of people that have joined, that have responded, are from Kettering General Hospital. We've got other NHS hospitals at 27%, and just people within IT at 21%, and private and primary care at 3% each. So this is very exciting for us that we're capturing people outside the trust. Then if you look at the word clouds on how they found the event, a lot of people have said interesting, informative, it's been, you know, enlightening, helpful, excellent, slick. Thank you for the positive words, and it's gearing us towards the right direction for next time. And I think we've got to try and make sure the standards are even a lot higher for next time. So thank you everyone for brilliant responses to what we've done today, and all the people that have spoken today to make this happen, and all the things that happened at the back, and also to our producers that have made this a very slick event. So I think it's still going as well. People are still putting information in there. Thank you. Please don't stop even after the event. If you remember anything, add it on. We've also got you know, what topics would people like, you know, at the next event? Just what would they want to talk about? And we've got some things like taking people on our journey, how to measure success, and what planning is needed for successful measured on new systems. I'm sure more will come, so keep them coming, keep those questions coming. Brilliant, thank you so much. I'm going to stop sharing my slides now. Brilliant, I hope that was good. So just to the last slide we've got here, just to say a big thank you to everyone that has participated in making this happen, from Andy Callow to Jacqueline Davis, to Jane Doyle, to Dr. Ajay Verma, Dr. Denley, and to Dion Rogers, the CCIO for Kettering General Hospital, and to all the staff that have been wonderful to log in. And if you have made it to this point, we have got a goodie bag for you. So the people that didn't make it might not know this now, so that's their problem for not waiting until the end. So hey, you've got a goodie bag. Now, if you're a KGH staff member, please go to Latimer House reception, and the address can be seen there. Please go pick out your goodie bags. You've got loads of digital, amazing digital items for you, so please go pick it up. Remember, there's social distancing, so when you get to the door, what we ask you to do is press the buzzer, tell them that you attended the digital seminar and you want your goodie bag, and what they'll do is come out and they will give you a goodie bag. And I'm telling you, there's limited numbers, so if I was you, as quick as you can from when we say go and get your goodie bags. I've got mine and I'm not showing off. I have got mine already, so please do get it. Thank you everybody for your help today. Dion, do you have any last and final words?
Thanks, Anna. I just want to say thank you to you, Anna, for putting this together. You've done an amazing job, and as you said, all the production team and speakers as well. It's been brilliant. It is just to say thank you for joining us. I'm aware for some people, you know, this may not be new information. This is about our journey going from 0 to 0, or from whatever Andy's bike analogy was. You know, we'll take the feedback for next time. We are planning another one in the winter. You know, and we'll take the feedback that it needs to be more benefits-based, more patient-based, and we'll absolutely do that if any of you are interested to see how we're gonna keep moving on this journey, really. So thank you to everyone.
Thank you very much. Bye-bye. Thank you, everyone. Thank you.
Thank you. Bye.